Start up again. Welcome back, and I hope that the initial discussions were productive, or at least creative in terms of starting to think about the problem you'll focus. I thought it might be nice to give you some examples so that you have an idea of what these problem trees look like when they're completed. So I'm going to just show you two examples before we move into the content for today's lecture, which is on moving from problem analysis to conceptual frameworks. And you'll hear a bit more about the difference between those two, but we'll also talk a bit about the role of theory. We started to talk about theory as underlying research paradigms yesterday, and we'll get a bit more into that. So these are two nice examples. This is one example on child health in Malawi, which is a country in southern Africa. And this is a process that they used to develop a problem analysis of child morbidity and mortality in Malawi. So obviously that was much more focused on the health issue and not the health systems or policy issue, but it'll give you a sense of the process that was undertaken to get to the problem tree. So this is from the Child Health Program, which is a joint program between InterAid, the Ministry of Health and Traditional Authorities in Malawi. And their goal was to reduce the number of children under 5, including neonates, who get sick or die from preventable diseases, which of course is a major global health goal everywhere, right? And they used a two-stage approach to assess the needs of the communities where they were operating their child health programs. So in this case, they actually used it as a community, a bottom-up method. So their process is that they ran a series of meetings with community representatives, in this case local chiefs, health center staff, and health district office staff. And during each of the meetings, the groups were asked to develop a problem tree showing what they thought were the root causes of child morbidity and mortality. And so in their case, they had a series of different problem trees, which were combined to make a final problem tree. And so I think that's also interesting, because imagine that you only had one topic, but you had 4 groups. Each of you would have come up with maybe a slightly different problem tree, and then you could have reached consensus in terms of one problem tree that incorporated everybody's ideas. So what they then did is they had some review meetings, which were held with the Traditional Authority Area Development Committee, the District Health Office, and the health area to validate the final problem tree. Now what I'm going to show you is the messy version, okay? Because I think it is nice to see the messy version, because it also reminds you that not everybody's going to end up with this perfection, right? It is essentially the process whereby you start with the problem in the middle, which is under 5 children who are getting and neonates who are getting preventable diseases. And then obviously a lot of work went into thinking about factors at different levels. And I'm assuming that the red and the black maybe colors are being used to distinguish between primary causes, secondary causes, tertiary causes. We don't know. But what is very interesting is that you can see here a whole range of things that are appearing on the problem tree, which are distal, which means quite far away in terms of causality. Religion, divorce, polygamy, lack of sustainability of NGO projects, lack of transport, and you're thinking, how is that related to child morbidity and mortality outcomes? But as a distal causal factor, obviously they would be thinking about the intermediate factors through which, how these things had an impact on. So that's just, I wanted to show you the messy process because I think it's also encouraging to know that you have to go through this process before you reach something that looks more polished. Yeah. Here you can see the identification of causal factors that leading to the problem. So my assumption is what they did is obviously they were dealing with community level stakeholders, but also people from the health system, and they probably separated them. And they got them to do 2 different problem trees, and then they brought them together. So at the community level, chiefs not being fully involved in health issues, beliefs, myths, misconceptions about health, inadequate male involvement, inadequate publicity, awareness, poverty, etc. At the health systems level, obviously people working within the health sector probably looked more within the health system, the services being provided, and where they were lagging in terms of program targets, etc. Inadequate staffing, inefficient scheduling, inadequate supplies and equipment, inadequate transport, health workers not living in the village clinic catchment area, inadequate supervision and feedback for health staff. Okay? So this, I just wanted to give you a flavor of what this exercise looked like in a very different context. And the second example is from, we couldn't actually locate a good example of something like this being done in the Indian context, but we did locate an example on veterinary health for farm animals, and obviously that is of interest for people who focus in this new emerging priority, or it's not emerging, but since about 10 years, priority of One Health, right? Is this interconnection between animal health, human health, and the environment. And this is a very interesting site. It's the Vet Helpline of India, and they say that their mission statement is to help organizations conduct studies and implement development projects in the field of animal health care, animal welfare, livestock development, and so on. And they prepared a diagram in the context of veterinary service delivery in India. And what I find interesting is that the website specifies that it is a living document. So if you go into the website, you yourself can put in further factors that you think are missing, and they get added on in some sort of live way. So this also explains why it looks quite complicated. But this is obviously a bit more polished. But again, I think it gives you a nice example of the core problem, which is poor farm animal veterinary service delivery. Yeah? I think what is very important to notice, because we're going to be moving from the problem analysis to a conceptual framework. And what I want to clarify for you is that you will notice that a problem analysis already states the issues in a negative way, or in a way where you understand why they're problematic. So inadequate emphasis on adoption of national standards, inadequate training, high number of untrained and so on, less number of skilled and motivated veterinarians. Whereas when we move to a conceptual framework, the way you are going to state these issues or variables is you're going to convert them, and this will look quite different. This will say something like national occupational, adherence to national occupational standards. So you're going to rephrase your problems as neutral variables that you can go out and measure, okay? And this is really, really important in a conceptual framework, because if you start your research already deciding that everything is suboptimal and problematic, it means you're starting from a biased point of view. So you've got to be open in the sense that you're saying, I have a hunch that things are not working as they should, but when I do the research, I've got to approach it in a neutral, objective manner, no matter what paradigm I'm coming from, okay? Even an activist paradigm is going to have to start with stating the variables in a neutral manner, although the variables they include might be different than the others, okay? Okay, so we're going to move now on to a lecture on theory, the role of theory in conceptual frameworks. So I'm just going to switch slides. I think we should be able to do that relatively easily. Here we go. Right, okay. So I'm going to give you a little task, okay? I'm going to put you in the field, in a field that might look familiar but not so familiar, okay? First of all, this is a field setting, yeah? This is a field setting where I have conducted field work. Just tell me, completely without reflecting too much on what you're on trying to interpret, but what do you see in this image? What strikes you? Okay? Anything. Just tell me what you see. Don't worry about trying to interpret it. Lack of? Okay, that's an interpretation. Just tell me what you see first. Okay, also an interpretation. Only tell me what you see. Also an interpretation. I want to see just observations. What do you see in this image? Women. Okay, you see women. Do you see any men? No. Okay, so it's a setting where there's predominantly women, number one. Okay? No interpretation yet. Okay? What else do you see? Health check is an interpretation. What do you see as opposed to what do you interpret? Anything? They have some sort of equipment. Okay. What kind of equipment do you see? Sorry? A stethoscope, that's an interpretation. Okay, interpretation. Okay, what I'm getting at is try to shed your lenses and just describe very objectively what you see, not what you interpret. Okay, so you see a bag, yeah? You see a book. You see something around the neck which is being used to do something. What else do you notice about this setting? Good? Not lab coat, interpretation. A white coat. What else?
All women have covered their heads.
Yeah, nice. All women have their heads covered.
Except for one.
What kind of space are they in? They're all seated. Exactly. Where are they? Outside. Outdoors. Wow, how do you know they're outdoors? Yeah, good. Sunlight. And? Interpretation. Sorry? Yeah, there's a wall. What can you tell me about the wall? Bricks, some mud bricks, good.
Yeah.
Okay, so this is something we're going to be doing a lot of later on when we get into methods. So observation is the primary method we use, but we do it intuitively. And what I was trying to show you already is that it was very difficult for you to look at this image in a completely neutral way. You already started to tell me what was going on here. Yeah? If I show this image in other countries, a lot of people immediately interpreted, they thought this was interesting that this lady is the only one who doesn't have her head covered. But they also interpreted that we were probably in a Muslim society, that there was some medical procedure going on, and I had to really push back and say, just tell me what you see, as opposed to what you observe, okay? So seeing is being able to describe things in a neutral way. Observation is where you start to bring in your interpretation of the situation. But I want to illustrate that what you were started to do, so if you now put on an interpretive lens, you would say there's some kind of medical equipment. Blood pressure is being measured. It's a predominantly female or predominantly a society where women's health is being treated separately, etc. All kinds of things you could start to interpret. And what I want to get across to you is that you are already using theory. Okay, you might say, no, that's not theoretical. It is, because you're already interpreting a situation. You're already giving it meaning. You're already setting these women in the context of something that you think is healthcare delivery, something that you think is possibly a patriarchal society. Yeah? So that is already theory. Okay? Because a lot of people have fear about the fact is that, oh, you know, that theory is very complex and abstract. It's not. We all start with an innate sense of interpretation and interpretive capacities. Okay? So, now I want you to look carefully, and we understand that this is some kind of health program going on. So now start to interpret what you see. Tell me things that you see which give you clues about what is going on in this picture. Could be a health camp. What makes you think it's a health camp? Good, good. They look like they're waiting for something. What are they waiting for? What do you think they're waiting for? Some kind of ANC checkup. Possibly. We can't see whether there's a pregnant ladies, but they're waiting for a checkup. What else do you interpret? Who's doing the delivery here? Who's doing the health service? Okay, why do you know this is somebody who is something apart from the other ladies? She's got a white coat. What else? What are the other things that tell you this person has some kind of authority? Stethoscope and? Book, bag, yeah. What else? What is on the bag? Okay. Yeah, good. It stands for BRAC. BRAC is an organization in Bangladesh. Okay, so we're in Bangladesh. Yeah? Okay, good. Anything else that you notice? Mm-hmm. Why do you think it's a rural setting? Yeah. Okay. They're sitting outside. There's a wall. They seem to be on some carpeting, etc. Okay. So let's move into what we notice and what we see. Okay. We see that all women are seated on the floor. We think they're outdoors. We notice that they all have covered heads, right? We also see something that tells us that this person is probably a health worker of some sort. We're not sure what kind of health worker. Could be a village health worker, could be a nurse, we're not really sure. But we know that because of the way they're dressed. The white lab coat, the stethoscope, the bag, the book. And we might be asking ourselves, what exactly is she doing? So some of you already said she's taking blood pressure, she's doing this. And we might start to inquire about the process. So how often is she doing this? To whom? How often are these health camps or whatever it is organized? And what kind of communication is taking place between this health worker and the ladies who are the beneficiaries of the program? So this is in fact a lady health worker in Bangladesh, okay? And you have similar cadres of health workers throughout South Asia. So I worked in both Bangladesh for a short time and also Pakistan, where lady health workers are very important. Why do you think they're particularly important, particularly in Pakistan, for example? Cultural, absolutely. Cultural, patriarchal society. So these lady health workers often have a mission to go over and beyond delivering services to women because they represent themselves, a woman who's been able to have a career mobility, and they have to, in a very patriarchal society, move around and have that social mobility, which is not necessarily granted to women, especially in a rural area. Okay? So I'm going to now suggest that, going back to our paradigms, okay, that each table, if you were able to do research in this setting, you might approach your research topics quite differently. Yeah? And I'm just going to give you, I'm not going to stick to the paradigms closely, but I will just give you 3 examples of the kind of research that you could do in this setting. Researcher 1 starts from an activist point of view. Yeah? Feminist researcher, interested in gender, in power, mobility, and they are actually not so interested in the health outcomes or the services being delivered, but they're interested in the lady health worker program and what possibilities that program offers for women in rural communities. Yeah? So they might be doing some life histories with these health workers. They might be asking who gets to be a health worker, how are they chosen, what is their professional socialization. Yeah? Or you might do some visual ethnography. So you might use some in-depth visual methods where you film a day in the life of these lady health workers to understand their interactions, both with men and women, because they're not just working in communities. They've got to somehow interact with the formal health system, which is male-dominated. So that's maybe your take on this situation. The second researcher is still an anthropologist, so still a social scientist. Sorry, the first researcher doesn't necessarily have to be a social scientist. But the second one is more interested in the social and the symbolic value of medicines and medical objects and technologies. And so they are interested in understanding how the specific things that you see around her, the stethoscope, the white lab coat, the book, the bag, how they invest her with a certain authority. Yeah? So this is an interesting topic. I had a student PhD student many, many years ago in Venezuela. And this person was a medical doctor, and he worked on the border of Venezuela and Colombia in an area where there were a lot of indigenous groups. And he was interested in the role of what they call over there simplified medical auxiliaries. And these were people who came often from indigenous communities themselves. And for them, they had this almost like a dual role, because they were not only providing medical services, but they were also trying to be the voice of indigenous communities, many of whom, would never be sitting at the table in terms of taking decisions. But what I found fascinating when I went to visit this student and I accompanied him with these medical auxiliaries on their job is how much these things meant to them, having a bag and having a book. And I'll never forget that this book, this training manual that these auxiliaries carried around, they would refer to it as the Bible. So it became so powerful in terms of a symbolic thing that because the communities would often refer to these medical auxiliaries, who are basic health workers, as doctor, because that's the only contact with the health system that they had, right? So going back to here, is when we're looking at things like this, these things, okay, is this matters because it immediately tells you something about the status of this person in relation to the other people, okay? So our third researcher might be a more straightforward public health researcher who's interested in human resources management. And their question is in health worker motivation and performance. So they might be a more positivist researcher. And they want to know what are the conditions and the criteria that are going to boost the performance of this health worker in the rural setting in order for them to be able to deliver the care that they're mandated to give. And you might be using some qualitative methods, some group discussions, to talk to younger health workers, older ones, ones who come from maybe different backgrounds. And you might use some ranking and rating exercises. You might use a method called a discrete choice experiment, where you ask them about their preferences. What would make the difference for you to settle in this area, which is very far away from all the excitements of living in a town? Is it a top up in your salary? Is it education for your children? Is it something else? Yeah? So often the question of incentivizing health workers in rural or remote settings is based on some research which tries to assess the relative weight of different kinds of incentives, financial and non-financial. Or you could use some kind of Likert scale, right, to assess preferences. But what I'm trying to illustrate to you is that the same setting, yeah, the same actors, you could be doing very, very different research. And the reason is why? So why would you come at this very differently? What determines how you look at this image or how you look at this setting? Your prior experience, exactly. What else? Sorry? Yeah, but where do your questions come from? What makes one person do this and the other person do this? Your interests, your experience, your what else? Your social context, maybe, yeah, okay. Okay. Your knowledge, your paradigm. I was looking for paradigm. But also your pragmatic interests, okay? If you're working for the health system, you have a certain amount of time to understand the situation of these lady health workers. You might have a much more targeted piece of research, which is more driven by, I have to find out by the end of my research, what will make these ladies stay in the program, as opposed to the drainage, which we see often. Difficult to retain people in programs like this, right? So a lot of different factors explain why you would do this research. I think what is also important to remember is that this is a context that you are sort of familiar with. So when you look at the image, you probably all thought, yeah, this is somewhere in South Asia. Okay? It's very different when I do this in a class with primarily European students, who will look at it and be fairly vague on the context. But for you, there were instantly things that are recognizable, yeah? And you were therefore much more able quickly to analyze probably the cultural issues in this image, whereas in a different context, people would pick up on other things. Okay? Good. So moving forward, this is really starting to get you thinking about the role of theory in research. And what I was asking you is essentially, the three researchers have different interpretations of their field observation. Why is that? Yeah, and you gave me a number of answers, background, experience, but I'm going to argue that you also come from particular theoretical backgrounds. Even if you might think of yourself as non-theoretical, even the positivist has a theory underlying what they want to measure and how they want to measure it. So in terms of the concepts or constructs that are relevant for each of these researchers, if we go back, okay, we said that the first person, the construct is probably gender, yeah, gender power. The second one is interested in social and symbolic value of objects. And there's a very interesting technique in anthropology called object biographies, where if you feel that it's difficult to talk to people directly about their lives, you can ask them about objects that are important to them. So if I went and interviewed those lady health workers and I said, what does this bag mean to you? Why is it important for your daily work? They might be much more interested to tell me the bag, the contents of the bag, what it means for their ability to have authority in the community, to be able to do their work, and so on. So it's a very interesting indirect research method. But here the construct is symbolic value of medicine and technologies. What is the construct of interest here? What's the main thing that you're theorizing in the last example? No? Motivation, exactly. It's motivation. Motivation and performance, yeah? Those are key constructs that you're trying to look at. So this is another thing that's very important. When you look at research, when you look at a paper, try to find the construct that is being unpacked, because that will give you clues about theory and the theoretical underpinnings. Okay, so again, we might go further and we might say, what kinds of assumptions drive each of the research topics? Okay, so just focusing on the last one, which is around health worker motivation, the way the researcher is posing the topic suggests that they think that incentives have something to do with motivation. Okay, so that's a theoretical proposition, that we think that health worker motivation and performance is dependent on non-financial or financial incentives. Yeah? So be very clear that every piece of research you do, even if you articulate it or not, you need to really think carefully about what are your assumptions that underlie your questions. Okay? In the second case, the researcher thinks that objects matter. Objects have a symbolic value. Okay? Beyond this being, a cup, this could be a symbol of conviviality, okay? Or it is a symbol of the fact that culturally, tea breaks at 11 o'clock are common here, et cetera, et cetera. I mean, whatever, right? But you start to, if you're a social scientist, you look at each kind of behavior, you look at dress, you look at mannerisms as symbolic of something, okay? Good. Now we're going back to our research cycle, and we're looking at where we are in the research cycle, and we're here, okay? So just remember what a research paradigm is. Don't forget that. Yeah, research paradigm is bigger than the theory. It is the way of framing what we know about reality, why we know what we know, epistemology, and how we can know it, methodology. Yeah, and it's grounded in fairly big assumptions about the world. So those paradigms that you all had are quite big in terms of framing reality. And they can be so pervasive and broadly accepted that we take them for granted, which is why the exercise was difficult, because it is difficult to recognize that positivism is in fact a paradigm, because most of us just take it for granted. That's the way we do things. We never think about what is actually underpinning the way we do things, right? So think about it as a pair of glasses. Okay, you put on a pair of glasses and you see the world in one way. You put in a pair of sunglasses, which suddenly are rose-colored, and everything looks much more beautiful, right? So it's similar in this way. So paradigms are grounded in overarching general assumptions about reality, whereas theories describe much more specific phenomena. Yeah? Motivation. What is my theory of motivation? Status or authority. What's my theory underlying how people demonstrate their status? Okay? Or the first topic was around gender. So gender power dynamics. What is my theory underlying how gender plays a role in the work of these women? Yeah? So your theories help you to answer this question, why and how, the questions that we often have about patterns that we observe in natural or social life. Okay? And by that I also mean that when you take yourselves out of one state and you move to the other, you often comment on the fact that, oh, things are done very differently here. Yeah? So why is that? And you start to interpret why they might be done differently. So we are constantly interpreting the world around us. Yeah? So you all are inherently have the capacity for theoretical thinking, because we do it all the time. Yeah? You make a judgment about this person who's walking through the door. Oh, the way they're dressed, yep, they're from such and such, and they're doing this, and they're, you know, this class, this caste, whatever. We do it all the time. So theory allows the researcher to make the links between what is abstract and what is concrete, between the theoretical and the empirical. The empirical is what you can see and touch and feel, and between thought and observation. Why is this important in health policy and systems research? Because we already said that health policy and systems research draws on multiple disciplinary perspectives. Yeah? You can be an economist, you can be a political scientist, you can be a historian, you can be a classic medical, biomedical, clinical scientist. All of those perspectives can play into health policy and systems research. And you'll see that as you develop your topics. And so therefore it is really important that we stand by, we recognize the assumptions that our discipline has trained us in, and the ways that it's trained us to see the phenomenon in a certain way. Okay? So, as I said, if you're looking at the story of the road traffic injuries, you're economist, you're a trauma specialist, you're a social scientist, they're going to see the problem slightly differently from their own lens, yeah, their own pair of glasses. In HPSR, we're also investigating complexity, yeah, because we said yesterday that when you think about health systems research, we're not looking at isolated building blocks. We're always looking at the impact that some change in one building block has on the whole system or on other parts of the system. And therefore, it's important, theory is also important because you need to have some way of explaining complex interrelationships. The third thing is you're often undertaking comparative analysis to generate conclusions that are relevant in different settings. So even though the case studies that you're doing in India, you're going to do a conceptual framework which may be applied in another setting. Yeah? Even though it's based, the problem analysis is very specific to India. Yeah? But as soon as you move to a conceptual framework, in principle, you should be able to say, okay, this is what we developed for the Indian setting. Now let's move it to Ethiopia, which also has a problem of road traffic injuries. Are there the same factors influencing the access to emergency care? Probably the variables will change slightly, but most likely they'll be quite similar, right? So the difference between the problem analysis, it is specific to the setting, whereas a conceptual framework is often more broadly generalizable. The fourth point is that health policy and systems research embraces iterative learning as a part of policy development and implementation. And that's why theory is critical, because theory is often, it's not a fixed endpoint. often we contribute in small ways to theoretical ideas, what's called sort of mini theories or mid-range theories. But by the end of our research, we are refining the theory. We're actually making a contribution to extend our understanding of whatever it is, gender and power and social relations and so on. Okay, now I'm going to help you move from observations to theory. Okay? So when you first looked at that image of the lady health workers in Bangladesh, I kept saying to you, nope, don't interpret. Just look at what you see. Because as soon as you started to observe, you were interpreting the situation. You were telling me this is a health situation, this is obviously some sort of nurse or health worker, this is probably a Muslim society, etc. You were interpreting the situation. So how do you go from those observations, which entail some interpretation of the situation, to formulating a theory? Let's look at an example. Let's say we are doing some research on understanding low uptake of HIV testing, yeah? And we're collecting different kinds of data because we think that we need to get perspectives from lots of different people. So we're collecting patient perspectives, so, or let's say community perspectives. We want to understand why people are reluctant to go for HIV testing, or when do people go, when do they not go? So we've got perspectives for them. We're collecting health provider views because we want to see whether the dynamic between providers and individuals makes a difference. And we're looking at how the systems work. Now, obviously, HIV testing has evolved very, very much in the last 20 years, from provider-initiated to voluntary, and now to self-testing, right? So those are changes in terms of how people approach testing. But for the sake of the example, just imagine we've collected this data, yeah? And we have a lot of observations. Now, many of you in your research will stop here. That's it. I did my work. Yeah, I collected this, I write it up, I summarize it, finish, thesis done. Yeah? But actually, you can do a lot more with that. You can take it forward theoretically. And I'm going to suggest just 4 possibilities for what the study on uptake of HIV testing might tell you in a broader kind of theoretical sense. So, and this is based on the fact that there is actually research that is based in this kind of theoretical paradigm, or not paradigm, theoretical direction. So I have my data on HIV testing, and some of you might be interested in risk perceptions, okay? So there's a body of theoretical knowledge around how people perceive and rank and contextualize risks. And if we look at our data, we might say there is something that it tells us about the differences in the ways people perceive risks. If I don't see HIV as a risk to me, even though my sexual behavior or other behaviors might be putting me at risk, what is going on there? And then you look at this carefully and you realize that for many people, a lot of other risks are much more pertinent. Getting into a road traffic injury ranks higher than worrying about HIV. Okay? So you situate your data on HIV testing within a theory, you develop a theory around risk perceptions. Yeah? The second person decides that actually it's not so much about risk, it's about how people understand their own identity in relation to HIV, sexual health and HIV. So if you realize when you look at your data that there is a lot of discussion or narrative around, I would never go for HIV testing because I'm not at risk because I'm a married middle-class businessman, or I'm a blah, 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 right? So you say, oh, this is interesting. Let's try to understand the ways in which people's perception of their social identity links to their willingness to test or not. Okay? So that's a different direction. Yeah? Another direction is it has something to do with medical technology. So, for example, there is research, and we did a little bit of this in some countries, in Kenya, to look at what it means to move from provider-initiated testing through to self-testing. And the fact that there may be uptake, variable uptake of HIV tests, might have something to do with the evolution of the way service delivery has happened. So what we found in Kenya was very interesting, which was that the US, at the time it was USAID, they initiated rapid self-tests. And they thought this is a way to empower women, yeah? They don't have to go to the facility, they don't have to discuss things, they don't have to face all this stigma. Just give them the test, let them read the test result themselves. This is empowering. Actually, it was the opposite. They didn't find it empowering at all. They said, I have to read this test by myself, I have to deal with this stress by myself. Where is the person to converse with, to share this diagnosis? Yeah? So this was very, very interesting work. So basically this direction, theoretical direction, is placing the emphasis on the mode of delivery of testing, the technology associated with it, and what it means for people. How transforming the process of testing from a provider interaction through to having to be yourself go forward, because many women are tested in ANC, right? To all the way through to self-tests, which you can essentially now purchase at the pharmacy. What does that mean for people? So this is another direction. And the fourth direction is something referred to as biopower. Does anybody have an idea of what that might refer to? Any clue? Any thought? What does it sound like? So it sounds like some sort of food for people that go to the gym. Okay, this is let me give you a clue. This is an activist standpoint. Does that help? Okay, so there's a body of theory which argues that HIV testing, like many other state-driven testing programs, public health surveillance programs, are a form of institutional power surveillance. So it's a Foucauldian perspective, which argues that this is one means of the state to control the population and to coerce them, okay? Because as we know, and this is very true in India, certainly from the 90s when I was working here, is that many people were co-opted into testing without really understanding what it was all about, and also didn't really understand what it meant. Often were tested without knowing, because providers were worried, and they were tested, but the results were handed over to the father or the brother-in-law or whatever it was, because it was thought that the woman couldn't possibly deal with the diagnosis by themselves. So those are other issues. In fact, that would maybe be a fifth circle around the gender dynamics. But this one is essentially looking at testing as one form of state surveillance. Okay? So I hope this example illustrates that you should not stop here. Yeah? This is one step of the way. Well, it's a big step of the way, is collecting your data. But reflecting on what that data means theoretically is the next step. Okay, so now I'm just going to give you this table. I'm going to pause for a minute, and just to share with you, thinking about the macro, the meso, and the micro, these are different areas that are theorized within each of these levels. So at the macro level, we often think about the political economy of health and healthcare. So the example we had yesterday, which was around the pharmaceutical industry, the role of foreign pharmaceutical industries and Indian pharmaceutical industry. That's a very political economy kind of question, because it's about the relationship between the industries, it's about their relative power, who has say, who drives the agenda, etc. Yeah? Distribution of power and resources, but also at the macro level, we're talking about social institutions that provide scripts and norms for health-related behavior. So this is essentially, when we talk about social institutions, we're talking about powerful cultural scripts. So when you were referring, I think one group was referring to beliefs or values, these are not individual. They're informed by the community you live in, right? So when you said myths or misconceptions, it's not so much about myths or misconceptions. It is about culturally normative ideas, which are very strong, because we know that if you go against culturally normative ideas and you say things or do things differently, often it leads to being stigmatized or being out, being sidelined, yeah? So generally this is also about the role of authoritative knowledge. So what knowledge, whose voice counts, yeah? We also saw that in some examples. At the meso level, we're looking more at that level of service delivery, the ways in which a particular trajectory at the meso level allows people to socialize into becoming, let's say, lady health workers. We're looking at the organizational culture, so leadership culture, management culture. We're looking at processes involved in health seeking, bargaining, negotiating, making decisions about care, forming collective groups. And we're looking at adaptation of global guidelines at the meso level. Okay, and the micro level is probably the one that you're most familiar with, because often the research you carry out in your master's programs are very micro level. Yeah? So that is, I don't think I need to go into that. So what is very, very important for me is that you think and you reflect more carefully about your assumptions that underlie the work that you do. Yeah? Make it explicit. What makes a theory is actually linking two or more concepts by a relationship. Yeah, so X drives motivation, okay? Y drives acceptance of testing or vaccines, okay? So you're often, a theoretical statement is one where you're looking at some form of association or causality. Yeah? And the key function of the theory is really to guide an understanding of why the world is the way it is. Yeah? Why are certain behaviors happening? Why are certain processes happening? And so on. It involves a great deal of simplification, but it aims to help you explain or predict a behavior, a process, or an outcome. So when we looked at the building blocks model, the one with the 6 things, it's not really a theory. Because it's not really, it's kind of a theory, in the sense that it's saying that there's something going on with those inputs that lead to those goals, the intermediate goals and the fundamental goals of the health system. But it's not a very dynamic theory. The control knobs, on the other hand, you could see how you could start to formulate theories along each of those knobs, which are effectively things that can be moved. They're movable knobs. So your task is always be aware and be explicit about your underlying assumptions. Now we're going to do the same exercise that we did yesterday, it's only yesterday, which is we're going to look at some papers and we're going to try to locate anything that tells you there is theory going on in this paper, okay? Because again, I want you to be able to read a paper and recognize what is informing the way that the researcher is writing this paper. Okay, so our first paper is from Health Policy and Planning, and it's about barriers and facilitators to nationwide implementation of the malaria vaccine in Ghana. What are the concepts that you think are important here? Don't worry, it doesn't have to be sophisticated, but what pops out for you? Barriers, facilitators, yeah, and? Implementation, yeah? So vaccine by itself is not necessarily a theory. Vaccine is a vaccine, yeah? But this gives you some clue, and implementation gives you a clue. Okay, now let's look at the actual paper. Interventions, so this is the background. Interventions such as malaria, anti-malarial drugs, bed nets, insecticides have helped curb the burden of malaria, but malaria remains a leading cause of morbidity and mortality. In 2019, these 3 countries with moderate to high transmission, started piloting the malaria vaccine. Using qualitative methods, this study examined the main factors, forces that will influence or hinder the nationwide implementation of the malaria vaccine if approved in Ghana. So we still don't really know theoretically how they analyze the data. So just looking at the background just tells us, well, it looks like a pretty straightforward study. They analyze barriers and facilitators. No real theory there yet. If we move on, we start to see more. So here we look at the method. Yeah? They're conducting in-depth interviews with implementing partners, researchers, academics in the public health sector in Ghana. And now is where your theory comes in. What's the theory here? Yeah, exactly. Okay. So there's some theory called force field analysis, and they used it to understand how organizations interact with their external environment. Now, going back to the macro, meso, micro, what level do you think this is? Macro, good. Why? Yeah, exactly. Okay. So you can already see now that this abstract is already giving you clues about where is the research situated. They could have done a micro level analysis, but they chose a theory and they chose to focus on the relationship across these organizations. Okay, good. Next one. Building patient trust in health systems, a qualitative study of face work in the context of the Aboriginal and Torres Strait Islander health worker role in Queensland, Australia. What are the clues that tell you what you think they might be theorizing here? Sorry? Patient trust and a concept that looks a bit strange here. Face work. What do you think face work is? Have you heard the expression in English to lose face? What does it mean? Uh-huh. Uh-huh. So that's what I guess might be going on there. I'm not sure. Yeah? Face work seems to be some kind of theoretical concept, but I'm assuming it has to do with trust, because the word trust is also there. So trust, reputation, etc. Yeah? So there's our theoretical concept, but we've also got the second one. Okay, let's look at the methods. In Australia, Aboriginal and so on health workers have played a central role in the delivery of frontline primary health care in rural areas. The study aimed to explore the structures, processes, and relationships that contribute to or inhibit their capacity and willingness to build trust in government health services. Okay, so what would you say, what level is this? Macro, meso, or micro? Good, why? Absolutely. Excellent. Okay, this is the clue: structures, powers, and relationships. So there's definitely something beyond the individual person, which is situated at their identity level. Their identity is part of a cadre of health workers. Okay, good. Methods and theory, drawing on in-depth interviews with, the study was grounded in the principle of critical realism. So here they're giving you the paradigm as well. Within this ontological positioning, face work theory integrated with Giddens' theory of structuration was incorporated to help understand the relationship between structural and agentic factors in the building of systems level trust. Okay, so hopefully now what we've been learning the last 2 days is coming together. Yeah, so you're recognizing things now. When you look at a paper, you're going to be much more alert to these issues. Good. The next one. Comparative policy analysis of adoption and implementation of sugar-sweetened beverage taxes in 16 countries. What is your clue in terms of what type of study? Yeah. Implementation, but also I should have actually circled comparative policy analysis, adoption and implementation. Okay. just having a guess without looking at the methods, what do you think might be the paradigm underpinning this one? Implementation should give you the clue. Realism, yeah. Possibly a realist study. Let's see though, I'm not sure, I'm not absolutely sure, I don't remember. So comparative, these are the three things. Let's look at it. Taxes on sugar-sweetened beverages are recommended as part of comprehensive policy action to prevent NCDs, have been adopted by only a quarter of WHO member states. The study aimed to analyze the characteristics and patterns of factors influencing adoption and implementation and policy learning between countries. To me, that sounds quite realist. But let's see. Comparative policy analysis in adapting diffusion of innovation theory. So not completely realist, but that is a theory which looks at the way in which innovations spread, knowledge spreads. Yeah? To a policy context, we observed that the uptake and diffusion of policy is influenced by a process of policy learning between countries. We thus adopted diffusion of innovation theory for our study framework, augmenting it with insights from theories of policy learning. So these are specific theories, but I still think this would fit quite well into a realist type of paradigm. Okay. All right, I'm going to pause there and just check whether everybody's on the same page or whether you had any questions. Yeah.
In the first example which we saw, I thought, in my perception, I think force field analysis would be the type of a methodology. But so what will be the theory that we're going to put in, the facilitators and the barriers which we used? So is that the theory force field analysis, or is this the methodology that we used, barriers and facilitators? That was my question.
Good question, very good question. The question is it the theory or is it the methodology? What would you respond to him? Sorry, just remind me of your name? Ashutosh, yeah. Is theory part of methodology or is it something separate? Okay. Do you remember the circle thing? Yeah, the research cycle. So where does theory come in? Does theory come in the beginning, middle, or end? Does it? It's all over, okay? So the methodology includes theory. You have theory in the beginning, but often we don't actually, often what happens, the reality of what happens, and many people will agree with this, is you might have some theory in the beginning, but as you collect the data and you analyze the data, another kind of idea comes in. And so you end up analyzing the data through a different theory than you started with. Or the theory is refined. But the point is that it is not theory influencing methods, end of story. It's quite iterative. And therefore, in this case, I think that force field analysis probably was brought in at a later stage. Okay, so we're now moving to conceptual frameworks. And I know that you haven't had a lot of time yet to think about the problem analysis, but we're going to have to jump in terms of the topic, but we can always come back to this, okay? But the first step that you are now undertaking is just analyzing the problem in terms of, understanding these causal, these contextual factors. But once you have done a problem analysis, you're going to be moving that into as I said, a different kind of framework, which is a framework that avoids telling us what is problematic, but instead conceptualizes those factors as neutral factors that could be measured quantitatively or qualitatively. So what makes theory explicit is often, a conceptual framework is one way of displaying your theory visually, yeah? It links, a theory, as I said before, it links two or more concepts by a proposed relationship. And the function of the theory, we've already said, is to guide you. It's a map of the way, why the world is the way it is. Okay? And by world, we can understand that as the construct that we're looking at or a bigger issue. It involves simplification, but it helps to explain or predict a behavior. And I've already said this, our task is to be explicit about our underlying assumptions. So a definition of a conceptual framework, it is the system of concepts, assumptions, expectations, beliefs, and theories that supports and informs your research. But I have to say that when you start, your conceptual research, your conceptual framework is primarily a concept or a model of what is out there that you plan to study and what's going on with these things, but it is your model. Yeah? It is, in the very beginning, a conceptual framework is often a combination of what you think is the issue, what you think drives the issue. It's a combination of looking at your problem analysis. It is also including things from the literature, because you will read up on the topic and you will realize that other researchers have already established links between different factors. It's also based on talking to your colleagues, informed colleagues, about what they think. And it's a tentative theory of the phenomenon that you're investigating. Usually what is involved in a conceptual framework is it's your constructs. That's why I always ask you the question, what is the construct or what is the concept that you're trying to unpack? And it identifies how you will operationalize the construct as a variable. Okay? So the example yesterday I gave you was stress in ASHA workers or the lady health workers that you just saw in Bangladesh. Okay? And I said that if I asked you, if we did the exercise and I said each table operationalize stress for me, yeah, which means break it down into measurable variables. Maybe each table would come up with some things that are similar, but some things that are different. Okay, so operationalizing involves making some decisions about what you can measure realistically, quantitatively or qualitatively, whether you want to, and your paradigm of research, because if you are a positivist, you're only going to look at variables that you can measure with structured tools, pretty much. Whereas if you're a qualitative researcher driven by a relativist paradigm, your concepts of stress might be different, because you think, I can look at these by interviewing people and I can, understand what stress means for these individuals. So you operationalize your concepts and then you try to determine the relationships across those variables. And in quantitative terms, we often talk about different kinds of variables. So when you have a relationship X influences Y, you often think about in between that X and Y are a range of other variables, which are called intervening or intermediate. And your independent and dependent variable in quantitative research often has some intervening or intermediate variables. And these are, those relationships are often expressed as hypotheses in quantitative work. Yeah? So, the simplest example I can think of is, if I increase the dose of X, Y is going to happen. Yeah? But you might say, well, in the middle of that, it's also dependent on whether I'm concurrently smoking or whether I am, I have low body weight, or etc. So there might be a whole bunch of intervening variables which influence the relationship between the medication taken and the outcome. That's a very kind of quantitative way of looking at things. But basically, you do the same thing for qualitative work, is you're still looking at the relationship between different concepts. And a conceptual framework very often involves some kind of diagram. So most of you in your studies will have encountered some kind of conceptual framework, or you would have been encouraged to develop one. What do they look like? It's usually a mapping of concepts and the relationships across them. But remember that the relationships are not only causal. Yeah? Not only X goes to Y. They could be hierarchical. They could be within circles. So certain things are grouped at a lower level and within things that are at a broader level. They could be based on similarity or opposition. And you can represent those things visually. Usually you use a range of colors or arrows or boxes or circles, but there are many ways to be more creative about this. Everybody likes to just do the boxes and the arrows, but you can use flow charts, okay? If you're trying to illustrate process, you can use a causal network of variables and their influences. You could use some sort of tree-like diagram, which is what we're doing, which is around the meanings of words, or you could use a Venn diagram where you're showing how things overlap. So things can be combined in diagrams, in frameworks, or they can be one or the other. So just to visualize a few examples, this one is understanding the origins of health and healthcare disparities from a health service research perspective. Key determinants of health disparities within the healthcare system, including individual, provider, and healthcare system factors. So this already tells you that they're looking at 3 levels. Yeah, individual, provider, and health system. And they have it's a very, very simple framework using a Venn diagram. So they see the healthcare system factors as overarching. Those are the broader structural, the issues, actually they're quite meso-level: health services organization, financing delivery, organizational culture, etc. And these impact on how patients relate to providers, and ultimately what they're really interested in is this issue. Yeah? So I think they were interested in understanding that the central clinical encounter, that there's disparities in that encounter that are influenced by provider characteristics and patient characteristics. A very simple one. This is another one. This is what is known as a kind of causal loop diagram. Okay? And the reason is because you can see that what they're interested in, there's nothing in the center, but they're interested in the relationship between nutrition, mortality, and poverty. And they've got some kind of explanations here in terms of understanding how things are related and how things lead to specific problems. But ultimately what you're seeing is a kind of a causal cycle whereby poverty influences your ability to have food security, but in turn, being undernourished might influence your ability to work properly, which leads to further poverty, which leads, and so on. So there's something circular about this diagram. Here's another one. This is an illustration of Indigenous Australian people's well-being, which includes appropriate work opportunities, education, access to bush food and medicine, security, capacity and freedom to learn cultural practices. So this is a specific conceptual framework which deals with well-being of Indigenous people. And it is, again, something around, it's again presenting a circular, a causal thing, but it's including a set of concepts around what is relevant for health and well-being of these people. Okay, now this is a different one. This is a conceptual framework of a specific intervention. And this intervention is an obesity prevention intervention. Yeah? So they're suggesting that they're looking at health determinants which influence, let's see what they influence. Okay, this is quite a complex one. There's a lot going on here. But basically they're trying to look at groups of factors. They group community factors, environmental factors, individual factors, and they look at the extent to which this, I think basically if I read this correctly, this is about the factors influencing community and individual capacity to be able to implement this intervention. Yeah, because if you look at the community level, it's resources, opportunities for learning, etc., self-efficacy, knowledge, skills, capacity. So this is something like a theory underpinning whether this obesity prevention intervention will work. They're trying to look at the factors that consist of an enabling environment for this intervention. Okay, it's also a conceptual framework. So I think you can see that conceptual frameworks can be different shapes and sizes and they look different, but essentially they're trying to explain your research, your phenomenon that you're trying to understand. So what is important is that the conceptual framework is not only descriptive, but it's also critical, because you need to understand and communicate what problems of gaps there have been with previous research and theory. You don't want to do a theoretical framework that duplicates what's out there already. What pathways and relationships remain to be explored and elucidated, and how your study can make an original contribution. So by the end of the week, you all will have conceptual frameworks for your group, for your topic, and you will be able to, on hand of the conceptual framework, if there are good conceptual frameworks, you each will be able to identify a question that lies within that conceptual framework. So your questions should be leading back to your conceptual framework leads back to your problem analysis. Okay? The sources are your knowledge, your existing theory and body of knowledge, your pilot research. Sometimes it's thought experiments. So asking what if. So sometimes a conceptual framework is almost like a projection of what will happen, like thinking about the HPV vaccine example. So what if we had uptake of, the HPV vaccine at 50% of those who actually need the vaccine? How would that impact on cervical cancer 10 years down the line? So sometimes the conceptual framework is used as the basis for research that's actually about modeling or predicting what's going to happen. So yeah, this is just repeating what we've said. This is a concept map of a theory. It's a visual display of a theory, and it's a very useful tool to use at different stages of your work. Yeah. So I want to say also that your conceptual framework is not fixed in stone. Yeah, it's something that you have maybe at the beginning of the research, and then you do a bit more reading, you do some preliminary data collection, and you adapt the conceptual framework. So, for example, when we sometimes we undertake a literature review as a task, right? Or a scoping review. And the scoping review is driven by a specific conceptual framework up front, but by the time you've reviewed all the literature, your conceptual framework is much more theoretically informed by the literature. So I'll give you an example. We recently did a scoping review we wanted to look at the relationship between mobility and health for men in a certain part of Southern Africa. And we had a very simplistic conceptual framework, which is how we thought mobility was affecting the men's ability to seek health and generally their health outcomes. And by the end of the research, or the end of the scoping review, we realized that we had oversimplified mobility. Why? Because there's many different types of mobility which lead to different kinds of health-seeking behavior. So migrants, long-term migrants, are very different than people who are moving for short-term occupational reasons. And so we had to make that initial framework much more sophisticated. Okay, so these are the steps. You're going to start with the problem. You don't have to worry about this now, because this is something that's going to happen after your problem analysis. You're going to start with your problem analysis. You're going to look at pre-existing sources of information. You're identifying concepts and contextual levels. You're operationalizing those concepts, and you're starting to display the relationships across the variables. So I don't want to. The issue is I don't really want to confuse you with because this is after problem analysis. So I'm not sure whether we should stop here. Yeah. Okay. So I'm just going to run through a couple of the steps, but we won't get into this exercise part. So assuming you have done the problem analysis, which is a way of looking at the problem and identifying why the problem is there. Yeah, this would be the next step. So you would start with the problem, which you have already done. That's part of your problem analysis. So that step's already done. you would look at how the problem has been studied in the literature. So for example, your topic is road traffic injuries, emergency care. Is there any existing literature that tries to explain why there are disparities in rural and urban settings with respect to trauma care? Yeah? Your framework is constructed, it's not found. So it means that you can't lift a framework from the literature, but you're going to try to synthesize different sources of information in order to get to your framework. You're going to pay attention to existing theories and body of research, but remember that any theory or any piece of research that you find is going to be limited. Yeah? You might find an interesting study from South India about road accidents. And you might say, oh, this is great, can we use this? And then remind yourself, no, this is just restricted to Karnataka. Yeah? So anything that you find, sometimes a paper that's presenting an interesting framework, be aware that it is just a framework. Yeah? It's just an iteration of a framework. The next step in terms of conceptual thinking is you're going to identify the concepts and the contextual level. So we can think about context. This is a classical, you probably have seen this typical socio-ecological model, right? Where you think about, okay, at each level, individual, household, community, national, what are the factors that are affecting my problem? You're already doing this in the problem analysis, yeah? But you're also thinking broader in terms of context, because sometimes there's different contexts that are relevant to your work, okay? And I think this is where a lot of conceptual frameworks fall short, because they're not explicit enough about the research paradigm that's informing the framework. So you get frameworks that are all based on an understanding that people's behaviors and beliefs are the thing that's driving the problem. But actually, if you're starting from a political point of view, you would argue very differently. Okay, so again, context helps you to situate the reason why you're doing the work and from whose perspective. Also bear in mind this, okay? Just remember that what I talked about before can be situated at the micro, meso, macro. And these are just examples, again, just to remind you, but hopefully they're getting clearer. And then the next step is going to be operationalizing the concept, yeah? So that means you're going to break the concept down into a variable that can be measured quantitatively or qualitatively. And remember that these are decisions that you have to make as a group. So if you say, I want to look at delays in access, or I want to look at trust, or I want to look at gendered power dynamics. That's a concept, but it's not broken down yet, because it doesn't tell us how you're going to measure it. All right? So what does trust mean actually? How am I going to look at that? Okay, so in a conceptual framework, everything that is displayed in the conceptual framework, I should be able to pick up and say, okay, interesting, you've broken this down. How are you going to assess this, either quantitatively or qualitatively? And you need to think about what determines the validity of the variable. Are you really measuring what you set out to measure? So each time you put something down in a conceptual framework, do a reality check. Look at the relationship. Is this really plausible, or is there something we're missing? Yeah? And then the next step is thinking about the relationship. What level are you examining it? Macro, meso, micro. How are you grouping things together? How do they relate? Are the influences direct or are they indirect? And what are the possible intervening variables? Okay? I think we're going to stop there. Yeah. Because now we're going to go into the group work. Okay, thanks. Can start? Okay, so we're going to continue. I know that we're moving at quite a quick pace, but we have the whole afternoon to spend working on the problem analysis and then moving into the conceptual framework, and we will definitely guide you along those steps because they're quite massive steps in terms of thinking and making decisions about what you prioritize and so on. So now imagine that you've already finished the exercise of the problem analysis and you have moved towards a conceptual framework. Okay, and I said that each of the groups would be working with a conceptual framework where they're able to locate their research questions within the framework. Okay, so a good conceptual framework helps you situate questions at macro, meso, micro, and vice versa. A good research question you should be able to locate it in the broader picture. So let's talk about what a good research question is, and we're going to end this session looking at some examples of research questions, and I'm going to ask you to decide whether you think they're strong questions or weak questions. As we said before, a good research question is always driven by a problem, a practical problem or an intellectual problem, a theoretical problem. It provides direction in terms of the topic, the approach, the methodology. Sometimes the question also specifies the site, the population, depends on the kinds of questions you're formulating. It sets boundaries very often. So it will specify that your research is taking place in a particular community or with a particular group of people and so on. What's important is that it's clear and it's specific, okay? Very often research questions are weak because the concept is not very clearly operationalized. So somebody says, you know, I want to study tribal women's beliefs and practices about something. And you think to yourself, well, what exactly do they mean by beliefs and practices? Okay, so anything that is a concept or a construct, you have to make sure that you're able to operationalize it later in your methodology. You also need a research question that you can actually address, that's feasible in terms of the time you have, in terms of the access to data, whether it's primary or secondary, but you would not be setting yourself up to set up a research question which you're not able to adequately answer, right? So it helps you to focus the topic and it links the topic to the research strategy, okay? So in terms of the consistency, let's revisit where we started. We started off with thinking about paradigms. Then we moved into theories. Then we go to conceptual frameworks, or we start to analyze the problem. We go to a conceptual framework. We then identify questions that are possible from that conceptual framework. We realize some of those questions are already answered. There's a lot of literature on some questions, and therefore we try to find a question which is relatively novel. Now, novelty depends on at what stage you are in your professional career. You might say for a master's student, it is too tall an order to be novel or original. Yeah, because it's difficult to actually do something that nobody else has ever done before. At a PhD level, you're expected to make a novel contribution. And even if that contribution is very tiny, but it is maybe the population or the strategy that you're using or the formulation of the question which gives it that novelty. And at a senior researcher level, you really are expected to deliver something which is new. Okay, so when you're developing health policy and systems research questions, that one of the things that you're thinking about is it is an applied field. Okay, even though we have been talking about the value and the use of social sciences, including history and geography and political science, ultimately you're trying to shed light on an issue that is of importance to policymakers, program managers, communities. Yeah? And so it's important to think about the overall purpose of the research. What is the research trying to achieve? Why is it being done? Who is it going to be useful for? How will it be useful? And how are you adding to the existing knowledge base? Yeah? So this is about purpose and relevance. Now we're going to look at two important different dimensions of questions. The first is that there are different levels of inquiry. So we're coming back to the macro, meso, micro. And we're reminding ourselves that a macro level analysis often is about looking at the architecture, the overall structure, the macro level structures, the oversight of the systems, the governance of the system, either by national or international guidelines or regulations, but we're also looking at the economics of the system and how that influences different aspects of service delivery and so on. The meso level is focusing on the functioning of the organizations and the systemic interventions. So what happens when the policy trickles down and your facility manager or your district health management team has to put this into place, yeah? What are the dynamics? What is the environment within which the policy is going to land? The policy is never going to land on a blank slate. This is very important to think about. Any kind of intervention that you introduce, whether it's a health workforce intervention, a new diagnostic, a new way of, triaging patients, you're bringing it into a system which already has an existing dynamic, a dynamic that is determined by the culture, the working culture, the leadership culture, but also by simple things like the space you have, yeah? Or is the infrastructure old? Is it new? Does it have new technology, old technology? So when you bring an intervention in, always think about the real world, the real life implications of introducing that. And that's what a lot of health systems and policy research, which I'm interested in, is focused on, is understanding those aspects of space, time, infrastructure within existing facility life, which influence how interventions are taken up. The micro-level analysis is considering the roles of individuals, as we said, providers, users, different kinds of managers. And remember that manager does not equal manager. So you have, in India, I remember this, that in the TB control program, there is such a long hierarchy of different kinds of managers involved in TB control. The STS, the STLS, the this, the this, the this, and so on. So some of them are at the same level and some of them are in charge of each other, etc. But it is quite a complicated system which engenders different kinds of relationships. And those working relationships across those actors are also going to have bearing on people's motivation, how they feel about their workplace, and so on. And so here at the micro level, we're interested in asking questions about how the system shapes and is shaped by their decisions, their behaviors, their actions. So number two, so the first way is thinking about the levels. Yeah, the second way you want to think about your questions is you locate them in terms of the kind of intent or purpose. And by intent or purpose, I mean, what is it that you are trying to do through your research? What are you aiming to uncover? So some research is purely descriptive. Okay, do you remember when we said there are two kinds of problems? Sometimes the problem is just a knowledge gap, and in other situations, a problem is something isn't as it should be. Yeah, but the knowledge gap type of problem is where you say, I simply do not know enough about this phenomenon. There's a big gap there. Yeah, so your intention is to describe the problem. In quantitative terms, you might say it's a descriptive, cross-sectional type of, I'm going to capture a snapshot of the situation at a given moment. I'm saying who, what, where, how much, how many. Sounds very quantitative. But of course, quantitative research is part of health policy and systems research, right? But you're looking at, use of the system, utilization, uptake of guidelines, whatever that is. But you're describing something about which we don't know yet much. The second type of study actually is close to descriptive. It's exploratory, yeah. But instead of describing, it is when you don't know much about. Maybe I should say exploratory comes before descriptive, because sometimes when you're going into a facility and you want to understand something about the dynamics of managerial culture there, and you're going to conduct a study because you don't know very much. So you need to observe a little bit for some period of time, interview some managers and their subordinates, and you want to get an exploratory sense of what's going on, okay? And then you say, oh, that's something interesting. I've noticed that the culture here of the management practices here are very gendered, or they're hierarchical, but there are ways to bypass this hierarchy, etc. And then you go out and do a descriptive study because you have a sense of the phenomena, the reality that you want to capture. Yeah? So exploratory is you don't really know what's going on yet. Yeah, you're just trying to see what could be an interesting topic in this area. Descriptive is you have an idea of what you want to measure, you know there's a gap, and you're going out and documenting that one. An explanatory is when you have an idea of what's happening, you've done a descriptive study, and you have analyzed some of that data, and it is showing up some interesting patterns or some interesting relationships across variables. So, things like we are finding, low utilization of this particular service in this group of people. Okay, what are the reasons for that, right? So you're trying to explain the patterns of low utilization. You're trying to explain the disparities that you see. Yeah. Evaluative is often clubbed up with explanatory, but it is a specific type of question because evaluation relates to a program, an intervention, something that you're introducing. Yeah, because evaluative is obviously trying to evaluate something against a norm, against what it was intended to do. So this is where a realist approach might come in as a form of evaluation. There are many different ways to do an evaluation, but a realist evaluation is a type of evaluative study because you are saying, what are the mechanisms through which this intervention achieves these outcomes under the given circumstances? So that's our second way of distinguishing questions, is the purpose of the study. Here is some examples. Now we're doing like a 2x2 table. So on the left-hand side, we have got the intent of the question, and on the right-hand side, we've got the different levels, okay? Here they've only, in this table, which comes from the reader that you have seen already, the Lucy Gilson reader, we can see that they have clubbed types of questions together. So exploratory and explanatory are clubbed together, normative and evaluative. So normative refers to when you have an idea of what is supposed to be the situation. So you have an intervention which is supposed to improve health worker motivation, or is supposed to improve diagnostic capacity, or is supposed to improve uptake of screening, okay? So normative simply means you as a researcher have an idea of what the ideal performance indicator is. So looking at here, so at the macro level, an example of an exploratory or an exploratory study is, why do informal health markets flourish in areas where publicly provided services are adequate? Okay, it's an exploratory question. Explanatory, what norms underpin the effective exercise of oversight by communities? So you might get confused here because you say, well, what's norms doing in that question? Why isn't it a normative question? But you're not actually doing any evaluation. You're just trying to assess how communities are holding the health system accountable here. Are there ways in which the community participates in some way of giving feedback to the health system? Yeah? Okay, on the meso level, we've got questions like, on the evaluative question, so how can political parties be effectively involved in a country's health planning process for universal health coverage? Okay, so what is normative or evaluative about that? What are you measuring against? universal health coverage. Okay, that's the norm. That is something, a goal, which is set. And you're saying, how are they going to be effectively involved in this process for universal health coverage? So this question assumes that they should be involved, yeah, in universal health coverage. Does a new financing mechanism protect the poorest households from catastrophic costs of accessing care? Again, the normative aspect here is a financial scheme should protect. Yeah? That's normative. In other words, a normative means this is what it is intended to do in the optimal situation. It's intended to protect against catastrophic costs. And so your question is an evaluative question, because you say, in the ideal scenario, my new financing mechanism is going to reduce the number of people who are spending out of pocket. And my research is going to look at whether this is actually the case, or under what circumstances is this the case, and where is it not the case. Can community accountability mechanisms have impact on health outcomes? It's again a type of evaluative question, because the assumption here is that we have introduced accountability mechanisms, for example, user feedback, suggestion boxes, things like that, where you have some way that the community feeds back their experiences of the health system, and we're going to now evaluate whether these are making a difference. Okay? Okay, in terms of the meso level, how can access to and uptake of screening and treatment programs for an epidemic condition be maximized? Again, often these questions, normative, evaluative, are implicitly talking about something that's been introduced, either a policy, a guideline, or an intervention. And here there's an intervention, right? There's an intervention which is a screening and treatment program. What are the reasons for how low efficiency of community governance structures in administering a decentralized fund scheme? Again, you're evaluating the community governance structures. Okay. Right, anything else? Let's just go to the micro level and go down again. So micro level exploratory. How do frontline health providers why do frontline health providers frequently diverge from recommended clinical guidelines? Now this is an interesting one. Some of you might say that sounds evaluative to me, because I have the norm, the standard, which is the recommended clinical guidelines, and I'm trying to understand why people diverge from that. So I personally would have put this in the evaluative category. I think the question, if you had asked it differently, for example, if you said, in what ways do frontline providers diverge from recommended clinical guidelines, that's a more descriptive question. But when you say why do they diverge, it's explanatory, but it's also evaluative. Okay. Okay, so this will take time to sink in, but don't worry, because what you're probably realizing is you get the input, you need to sleep on it, and then it'll become clear the next day again. Okay? But essentially, so we've already understood these are the two ways to think about questions. Situate them at a given level, and also clarify the purpose or the intent of the question. The third point is the question of whether your research question is touching on the whole field or a specific policy. So is the research focusing on the field as a whole, and will it expand knowledge of the nature and functioning of key elements of health policy and systems, or is it focusing on a particular policy that which will support its implementation? So when we talk about field as a whole, we might say there might be questions which is, how do countries' health financing mechanisms impact on the efficiency of the system? And you do a comparison of 16 countries. Okay? you're going to contribute to the field as a whole of understanding the relationship between health financing and performance of the system. But if you go into a specific policy and you say, in India, how do the latest budget reforms impact on the maternal health program? That's more specific because it will also most likely have relevance just for the Indian context. Okay? Okay, so this is, again, to distinguish questions about the policy or questions about the field, right? And again, they're distinguishing here, they've clubbed together. Don't worry so much about the way they're clubbing. I think they were just trying to save space in the reader. So questions about a specific policy. Should this policy be adopted? How does policy X impact on health-seeking behavior? What actor management strategies are likely to be the most useful in supporting implementation, and so on? On the descriptive side, explanatory side, which agencies are stakeholders in this policy? What positions do they take? How did the policy come about? Is there capacity to implement it? And so on. And when we move into the broader questions that are relevant to the field, you'll see that the questions are pitched much more broadly. What type of health systems performs best? That's a huge question. Can you imagine the kind of analysis that would need to be undertaken to answer that question? Yeah? What are the different approaches to actor management that can be considered by those seeking to manage policy change? So what they mean by actor management is the control knobs, yeah? Issues of regulation, incentivization, and so on. So how do I introduce policies that will influence provider behavior, that may or may not bring about better policy implementation? And on the last field, we have what are patterns of health-seeking behavior? What influences that behavior? How is the health system organized at present? What if a new provider was available? How would health-seeking behavior change? I think these are also broader questions because they're not specific to a setting. Yeah, but you're saying usually these are studies that involve multiple countries, and often, you know, a bigger research proposal is a comparative research proposal because you want to contribute to the field more broadly. You want the research to be generalizable across different settings. Okay, now there are some very helpful frameworks, okay, for formulating research questions, and you may be familiar with these already. So there's lots of them, and I'm going to provide you with a link that shows you different frameworks. But one of them is called Peacock, yeah? And basically, it reminds you that if you formulate a question according to the Peacock framework, you need to focus on the P, which is what is the person, population, or problem? Who or what is the focus of the research? Okay? So it might be the case of people. Why? Because your research wants to target, your HPSR research is looking at a specific population, managers or people affected by a certain condition that are experiencing issues with the system. Or you might have a broader population, so people attending outpatient services. Or you might have a specific problem. So what is the focus of the research? The second is, and this is why this kind of frame works for intervention research, is what is the intervention that's being investigated? But remember we said that an intervention can be broadly thought of, yeah? It's not just introducing a new drug or introducing a new screening mechanism. The intervention can be the policy or the new, we put in a community health officer. Okay, that's an intervention because we think that it's going to solve some issue in the health system. Okay, we put in new trauma care units. That's an intervention. So think about intervention broadly. Comparison, what intervention is this being compared with, if any? Outcome, what are the effects of the intervention? And context, in what context or place is the problem being investigated? So these are just things that you might remember when you formulate your question that's derived from the conceptual framework. Is the level of specificity is quite important. So rather than saying something like, you know, why do people what drives, health seeking for trauma centers, or what drives delays. You want to be as specific as you can. You want to say, okay, what influences delays of this category of people in reaching this facility within a specific amount of time, etc. Okay, so specificity is quite important. This is another kind of framework. It's called SPICE. So this one focuses on the setting, the perspective, whose perspective is being researched. Again, the intervention or the area of interest, the comparison, if there is any. I'm not saying every question has comparison, right? Because sometimes the question is purely descriptive. And the evaluation, so what are the outcomes? So I wouldn't worry too much about this because there's lots and lots of these kind of frameworks, but they're all more or less covering the same things. Some are better for evaluative questions, and some are better for explanatory, and some are better for descriptive ones. Okay, so this is the exercise that we will be doing tomorrow, which is that you will go through this journey from the problem analysis to the conceptual framework, and then you're going to try to locate questions in each of these boxes, which is not easy. It's going to be hard. I can say that already. So be well equipped in terms of energy and enthusiasm, because this one is a tough exercise. But we will get there, I promise you. Okay, everybody gets there. Okay, so we're going to wrap up from today's session overall, and I think we're just wrapping up with the points from some of yesterday's sessions as well before we look at some research questions. So research is driven by a problem, but conceptual frameworks are neutral. A conceptual framework is not the problem analysis, it's the next step. The conceptual framework conceptualizes relationships and pathways to explain an issue, and it's important to think about the indirect and the direct influences. There's a difference between theory and conceptual framework. Okay? A theory might drive a conceptual framework, but you could have multiple theoretical influences on a conceptual framework. There's different ways to develop and formulate questions, and we've given you a sense of the level, the purpose, and then we've also thought about some of the frameworks, the type of specificity that's needed. We will go into developing a conceptual framework in practice more, but I've already started to outline the steps that you're going to take. And then I've also shared with you, based on that image, which I hope sticks with you, because often the visual sticks with you, of the lady health workers in Bangladesh, that you can use different theoretical lenses for the same setting. And I think that's what's very, very exciting, because I'm sure that you do that as master's students here, is often you have the opportunity to be attached to one single project or one program, but you've got to come up with different questions, yeah? So often those questions are really influenced by your lenses. Okay, so now we're going to move into a little bit of interaction again. And I think we can keep the camera on, that's fine for these points. I want you to look at these questions, and I want you to tell me whether they're good questions, okay questions, or poor questions. And I want you to tell me why, all right? So question 1, what are the main structural and social factors influencing access to TB treatment among Eastern European migrants with tuberculosis in the United Kingdom? How would you rank this question? Do you think this question sounds okay as a research question? It's a good question. Okay. Yep. Yeah. Yeah.
I think main structural and social factor is a bit broad. That can be narrowed down.
Good. Okay, very nice. Anything else? Any other table want to agree or dissent? Okay, good. So the question is, can you do both? Can you do structural and social? I think you probably can, because when you talk to people, they don't divide it. They're talking about poverty. You're not going to say, no, I don't want to hear about your poverty. I just want to hear about your social issues, right? They're going to speak to you about many things that affect their treatment. And but it's a good point, whether you put that already in the question. Yeah? Okay, but in general, we would agree that the first one is not bad, right? We would give it, what would you give it out of 10? 6? Oof, you're very harsh on this side. 9? Okay, that's better. 8? Okay, good. All right. Okay, what about the next one? What are adolescent girls' experience of family planning services in India? No? Not good? Okay, why don't you like it?
I think the so family planning services, the target population may be like, I think adolescent girls may or may not fit
Okay, good.
the definition.
So it doesn't seem the right fit for the country setting, but what
Yeah.
else is going on here? Anybody else from that table?
Like it can be put like this: what are the family planning services available for reproductive age group women in India? We can put like that.
Okay, but you're changing the question into a descriptive question. So I want the question to stay as is, but I want you to tell me what's wrong with it. What is missing in terms of specificity? What could be added to make it more specific?
Like what kind of family planning services we
Good.
are?
Yes, exactly. What type of family planning services? Yeah? Are we talking about... it's interesting that you raised this issue that this isn't probably the question that would be work here, because nobody in other classes notices that, because this is a question that is acceptable. Adolescent girls from a certain age might be involved in sexual activity, and therefore we need to think about family or contraceptive services, right? So the issue is a very good question. You're saying, what do we mean by family planning services? What else? What else needs to be operationalized here? Something very basic. Sorry?
the age group of the target
Exactly.
population.
Is an adolescent girl 15 to 19? Are they 12 to 19? Are they what do we mean by adolescent girls? Yeah? And another thing that needs to be broken down.
Probably
India.
the experiences also, in terms of saying utility of the family planning services, or in terms of availability of the family planning services. This.
I'm not so worried about that, because I think that if you're coming from a relativist point of view, you just want to understand their experiences, but your point is taken. Is it use of the services, or is it getting to the service, or is it knowledge? Not quite sure. It could be all of the above. Yeah? But the other issue is India. I mean, for goodness sake, India, the whole country? Right? So you would expect, because every state is so different, that I would have expected to see this broken down, unless you're really going to do this study across the whole country. Yeah? Okay. So how would you rank this one out of 10? 5 or 6? 6. Okay. This one's being a little more generous. And you're giving it 5 or 4. Oof. Wow. Okay. I'll know not to submit a proposal to you. Okay. What about this one? Does the fast food industry affect the rise of non-communicable diseases in Ghana? What is good about this and what is not so good? Interesting question or not?
When they are talking about NCD,
Yeah.
I think exactly, I mean, NCD is an umbrella term,
Yeah.
so which ones are they focusing
Good.
on? And
Yeah.
that way.
What else needs to be operationalized?
What kind of
food
fast
industry.
food?
Yeah, good. Okay. What else?
The country.
Country's okay here. Okay. Yeah.
Questions? directly give you an answer of either yes or no. Does the fast food industry affect the rise? It's yes or no.
Absolutely, absolutely. It's a spoon feeding question.
Yes.
Does it influence? It's already kind of pushing it in a certain direction. Yes, no. Yeah? So how would you reformulate it? Go ahead.
Probably I'll start with how the fast food industry affect and
Okay, how, in what ways, to what extent? Yeah? Okay, good. Okay, next one. What forms of evidence drive health policy in the context of post-conflict health sector rehabilitation in Sierra Leone, and how? Is this one specific? Yeah, nodding. What do you think? Table over there. Do you like this question? No? Okay. Oh, that's sad.
Like the question is saying like what forms of evidence drive health policies in context of post-conflict health sector rehabilitation in like and how. But we are not telling like before that we can look like is there any evidence? Is
Good.
there any evidence?
Very nice point. This assumes that there is evidence that drives health policy, right?
Yes.
Very good. So I don't think this is a bad question, because you might end up with the research saying very limited evidence drives policy. But you're right to say that this assumes that evidence is driving policy. Okay, anything else about this question? Is it specific enough with regards to the framing? Yeah? What would you give it out of 10? Anybody? Less than 5? More than 5? 7? Yeah, that seems reasonable. I think it's a decent question. Yeah? What about this one? How did the global fund skew health systems delivery in Southern Africa? Too big? Ah. My thing is going to run out in a minute. Too broad, yeah? Time period, good. Excellent. Time period, what else?
What kind of health systems?
Okay. What does skewing mean? Yeah? Skewing is a bit vague, right? Health systems delivery is also huge. Maternal health services, all health services, yeah? Okay, so this one I would give a 5 max, yeah? The last one is how do health workers, why do health workers fail to comply with ethical guidelines for HIV testing during ANC? What is, I'm going to say this is problematic already. Why is it problematic?
The location, the studies.
Location is missing,
Setting
and?
is missing.
Health worker type, yeah, and?
Guidelines of,
Guidelines are okay, that's okay. What is this assuming? What is the question assuming?
Yeah, the assumption of failure, maybe. Assumption of failure.
Assumption of failure, exactly. Yeah, excellent. Okay, so this question is also shaped already in a way that is negative, right? It is assuming health workers fail to comply. Okay, so we should try to reframe it in a more neutral manner. So, how do health workers respond or take up guidelines for HIV testing? That's descriptive. But maybe we've already done that study and we're seeing that they do fail to comply, and therefore we're asking why do they not adhere? But fail is a bit of a harsh word. Okay? Okay, good.
Ma'am, in point number 5 question,
Yeah.
I think the researcher is trying to be neutral while writing the word skew, can go either positive or the negative.
Negative.
If not, then what is the better word to use here?
I think if you want to be completely neutral, you could say how did distribution of the funds through the global fund, or how did allocation through the global fund affect health systems delivery of services for this program in Malawi or Zambia. Southern Africa is also massive. Okay? But on the other hand, none of these questions are terrible, yeah? Because question number 5 could be a broad study. And they specify we're looking at Zambia, Malawi, and South Africa. Okay, good. So we're going to stop there. We're going to break, and we will stop the recording. So thank you very much. Oops. Sorry.